All right, looks like we're live. Good afternoon, everybody. Good to see folks again. It looks like a lot of participants are trickling in now. I hope you all had a very satisfying lunch. Bit of deja vu here. You may have tuned in about 2 hours ago to see me introduce this same speaker, but on a different topic now. Same housekeeping as every other session. Please ask questions as you have them, but in the chat box, you're all muted, so we won't be able to hear you if you try unmuting. I'll be paying attention to both the Zoom chat box as well as the Whova chat box. So ask questions in both of those as you have them. If you have any questions about certificates, don't worry, we'll take care of that. We'll just keep an eye out for an email from us after today when the series is fully finished. All right, now this is the true deja vu part. I get to reintroduce Dr. Colleen Cowdery, who is serving as our new medical director, chief medical officer, at the Washington Poison Center, and she completed her toxicology fellowship with the Oregon Poison Center at the Oregon Health and Science University just before recently moving to Seattle. So, Dr. Cowdery, welcome. Great to see you again, and I'll turn it over to you.
All right, thank you so much. Here I am again. This time I will be talking about the epidemiology of poisonings, overdoses in the news. So this is going to focus primarily on opioid overdoses and fentanyl sort of specifically because, first of all, on a national and international level, that is sort of the overwhelming poisoning of note when it comes to the news. Opioid overdoses, I'm sure this is not a surprise to anybody. They have risen just tremendously in the past 20 years. There has been lots and lots and lots of research, and with that comes lots and lots of news stories. Some of it coming directly from research stories, and some of it coming from human interest or certain events that caught the public's attention. And unfortunately, as frequently happens whenever you get many news stories about one topic, particularly a topic as large and complicated as a global epidemic, there's a lot of news that seems like it can be contradictory. So we're going to dig into that. As with my last presentation, we have some disclaimers, no financial disclosures. I do not have a degree in epidemiology. We are not going to be digging into the meat of epidemiology when it comes to like statistical testing or different like data sampling methods. I leave that to somebody with more expertise in this than I am. I'm going to be talking more specifically about just the general sources of where numbers are coming from when we talk about overdoses. So different major sources that you are most likely to run into when you're looking at numbers about overdoses, particularly in the news. So we're going to start with just a smattering of headlines. These are all very recent headlines. We've got drug overdose deaths sharply fell in 2024. Fentanyl went down, but meth spiked. Okay. But now here's a health alert from 2024 saying that opioid overdose events are going up, enough that we need to make a health alert about it. Okay. Here's Yakima County. Fentanyl deaths are down in 2025, but they had been up in 2024. But now published that same day is a story saying that US drug overdose deaths are in fact going up after they had been going down. So how do we handle this kind of news coming in within a pretty short period of time, sometimes even the same day, and at least on the surface, seeming like they're saying different things? So where are these numbers coming from? What are some general limitations and complications to keep in mind when we're looking at different sources of data? what are the important elements of scientific communication and what happens when we mess it up? And what can we do to reduce confusion when we are trying to communicate this information, whether it is directly to the lay public as a part of a health communique, or if we're talking to a reporter about some recent research or numbers, what can we do to try to minimize confusion? This is certainly not going to be an exhaustive list of sources, but here are some. So these two are out of order. EMS and police response data, data from hospitals or care systems. Well, we're really out of order. Self-reported data, where you essentially just ask people. Um, Local or state medical examiners, huge source. The National Poison Data System, which we'll talk a little bit more about later. And then federal organizations like CDC. So self-report response data, obviously it's not going to be fatality based because you're asking somebody something, they're answering you. On the upside, it's relatively inexpensive, and potentially you can get a lot of broad data in a relatively short period of time, but there are a lot of downsides to self-report data. Uh, Particularly if you're talking about a stigmatized subject where people consciously or unconsciously maybe don't want to fully disclose things. Um, there are studies that show that both adults and adolescents have been found to underreport drug use, risky behaviors, things that maybe they think will make them not look good. So any kind of self-report response data when it comes to drug use definitely has some asterisks that you can't ignore. EMS and police response data is a great source of information. It is not necessarily fatality data. It is based on whether it's 911 calls or direct contact between EMS and police and the public. Um, there are many places in the United States that have a lot of community access to naloxone, which is great and I love. And many times what we see in those locations is that there may be an overdose and there's either bystander use of a naloxone or a first responder use. And then that person may decline transportation to a hospital. So they don't die, thankfully, and they never see the inside of a hospital. They just get naloxone and then go on their way. So first responder data is great for assessing a fuller picture of all overdoses, not just the fatalities. Because if you think about it, if you saw a rising number of deaths, it's hard to put that number into place without knowing how many non-fatal overdoses there are, and you're never going to get that information from a medical examiner. So naloxone use does not necessarily mean that they died or went to a hospital. Downside of this is you're very likely not going to get an outcome, whether or not it's because the person in question just decided to leave and go home, or whether they went to the hospital and then, EMS doesn't have any more contact with them because now they're in a hospital. So outcomes, you don't get as much, but you get a broader picture of like injury burden. Now, getting data directly from a hospital or in some cases a care network within a region, strengths and weaknesses to that. So the regionality is the strength and the weakness. So you can get more granular to a specific area than you can get with like a national database. But then it's hard to take that data and say it applies anywhere else. If you're doing a study in, San Francisco, can you bring that data and say anything about rural Alabama? Probably not. But you might be able to say something useful about San Francisco. You may even be able to apply it to similar cities, but there's drawbacks to that. If you're only looking at data from your hospital or care network, any out-of-hospital events are going to be missed, including fatalities that then never went on to a hospital. But you may be able to get more specific questions answered. Medical examiner data. This was brought up in my previous talk. This is huge. This is great for any sort of fatality-based questions. You can get data very, very locally. You can get it on a state level, and then all of the states report their data nationally, and so you can answer questions on the level of an entire country. When we talk about ME data, obviously it's just fatalities, so no non-fatal exposures are really getting reflected in this. And when we are talking about searchable medical examiner data, we are talking about, death records. And in case anybody in the audience has not ever filled one of these out or seen one before, this is what we are looking at, and this is what's actually getting searched when you're trying to answer a research question. So this part in the middle, I'm not sure if you can see my mouse here, but underneath cause of death, where you have immediate cause and then sequentially list the conditions resulting in the last condition of, death, such as cardiac arrest or respiratory arrest. This is where death records can get a little bit hairy because, for example, let's say somebody died because they stopped breathing. You could list that, let's say they fell, and when they fell, they hit their head, and when they hit their head, they developed a brain bleed, and then the brain bleed caused swelling, which caused brain herniation, and then they stopped breathing and they died. And that is the order with fancy doctor language that you would put to determine their cause of death. The last step is they stopped breathing. It could just as easily be they used fentanyl and then they stopped breathing. But you also can get really complicated ones, like maybe they tested positive for fentanyl, and we think that's why they crashed their car. And then they had a critical polytrauma with a brain bleed and brain herniation, and they stopped breathing. And so you can see how you can very easily end up in situations where you're trying to tease apart a situation that you don't have a perfect understanding of. And you're trying to decide, well, should I put fentanyl as the immediate cause? Do I put fentanyl down as a significant condition contributing? Do I mention it at all? So you definitely can end up with cases that are not caught because of how the death certificate was filled out, which either due to a lack of understanding of how to do cause of death or just imperfect understanding of what happened to the human being, things don't get accurately recorded. And then, of course, this has to get logged into a system, and maybe you just put in the wrong code, even though you intended to put something else. Additionally, I do want to point out, because this is a something that I learned and thought was very interesting. You see where the signatures are at the bottom of this, there's a place for a certifying physician to sign and a place for a medical examiner or coroner to sign. And I always think it is very interesting, the system used in the United States with medical examiners and coroners, because a medical examiner, by definition, they have to be a medically trained person. They're physicians. Coroners are not. They are a public official. Depending on where you live, they may or may not be publicly elected officials. In some places, if you get a certain job, you just kind of also along with it become the coroner, such as in Nebraska, if you're the district attorney, you're the coroner as well. In some places, it's the sheriff. There may be little or no training that comes along with being given the title of coroner. And now you are determining cause of death. And you can definitely see where you may end up with significant regional variation in how these are filled out, depending on which professional is filling out this form and how much training they have and how much knowledge they have of the person's condition when they died and why they died. So We love medical examiner data, and it is a great source of data, and I'm certainly not saying we should stop using it. But sometimes death reports can be a little bit hairier when you start digging into the actual data that's going into the database. And also just because I think it's interesting, death certificates are a lot more recent than many people may think. For many, 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 many years in Western Europe and the Americas, most death record data was kept by churches, and like families' Bibles would have pages. They would come to you when you got it new with pages at the beginning to record births and deaths. And this is how birth and deaths were recorded, and that was it. And if your, your county's church burned down, then all of the birth and death records were lost. In 1639, the Massachusetts Bay Colony was the first Western secular death record system to be developed. And it wasn't until 1910 that the United States actually standardized a model death certificate. I've read old death certificates where like the cause of death was fell down dead. Not the most useful, but I guess an accurate description. And in the 60s, we developed the Mortality Medical Data System, which is this federal system that draws in data from all of our vital registration offices in each state to help us look at data on a national level about what is causing death. So automated entry, classification, and retrieval has really allowed us to do some much more powerful research than prior to having it. This brings us to our National Poison Data System, which is also a great system for looking at any kind of overdose data. It is all voluntary reported information to US poison centers. It can come from members of the public or healthcare providers. And, there are definitely well-known biases that come with this data system. One of which being that mild cases are known to be underreported, because if it's very mild, maybe nobody calls the poison center because they don't need additional advice or assistance. And on the other end of the spectrum, very, very, very severe cases that end in death before anybody can intervene also tend to be underreported to the poison center, because by the time someone gets involved, there is no longer need for medical consultation. And very few people just report this data to us from a epidemiology standpoint, though they could. Severe cases are known to be overrepresented because those are the patients that physicians most want to get a toxicologist's input on. And once the data gets sent to our national system, there's a loss of a lot of the high definition. You lose a lot of details because the national report, there's only so much you can put into it. And so the things that are searchable and the questions that you can answer, you trade off big data for detail. And then our federal groups, of which the CDC runs many of these programs. National Vital Statistics has the Mortality Medical Data System, which I talked about before, all of the states sending in their death records from their vital registration offices. They have their own reporting systems and data collection tools. I think this is pronounced SUDORs. That's how I've been saying it. I don't know if I've been saying it wrong. Is the state unintentional drug overdose reporting system. They also have Wonder, wide-ranging online data for epidemiologic research. I think someone enjoyed coming up with that acronym. They have more also, and each of these has its own inclusion and exclusion criteria. This is getting much more detailed than any member of the lay public is ever going to want to read about in depth if they're just, pulling up an article about fentanyl overdoses. but it's really important for us to know about so that if we get like, you know, 30 seconds of, soundbite, you understand your data source well enough to have a single statement of like, and be aware that this is the number one limitation to be aware of in this data. So for example, pseudors, it does specifically include illegal drugs such as, heroin and fentanyl and cocaine, except for some reason, it does not include inhalants that have another use. So if you wanted to, present some data on inhalant abuse, can't use this data source. It also doesn't include alcohol and tobacco. Wonder it draws from the death records. So the things I talked about before, just being aware of the limitations that come from using death records. And, especially for new and emerging things. So if you listened to our previous talk on nitazines, they're still, emerging, particularly a little while ago when nobody was really testing for them. You can't search for any useful data on nitazines if nobody is recording it on the death certificate. So it has to be something that is like being tested for and being included on death certificates. Otherwise, it's not going to be in the reporting system. Additionally, something that is incredibly important to know about the National Vital Statistics System is that it doesn't just automatically pull all of the data from the states. It's staggered. Each state needs to send in their data, and they've got a deadline to do it, but maybe something comes up and maybe they miss their deadline. Maybe they are still investigating a ton of cases, so they can only send in a certain percentage of their data. So if you look at the data on the CDC website, it is always listed as provisional, because there's always a certain percentage that just hasn't been reported yet. And what that means is that you may end up getting changing information. So let's, after that, fire hose of information about data sources, let's look at some examples of news stories drawing data from different areas. So, and all of these stories are very recent. We've got nearly 1,500 suspected opioid overdoses reported across Washington state in July. So this was reported on August 7th. Always pay close attention on whether something is reporting overdoses or fatalities, because that's right off the bat going to give you a hint of what source of data is or is not being used. This is based on monthly reporting from the Washington EMS information system. Important to know, does not include all EMS agencies. Different EMS agencies have their own reporting levels. They have different data entry practices. It's better than nothing, to be sure, but it is not a complete picture, and you may see differences region by region, which may lead you to inaccurately like compare, like, oh, this eastern region with this southern region. It's much more valuable to look at trends across time than just trying to compare two neighbors that may have different EMS reporting practices. Also important to know that anything coming from the EMS agency is probably going to just be listed as suspected overdoses, because in the same way that EMS doesn't really get outcomes, they're not usually confirming testing. That's going to happen either by like a forensic team or at a hospital. Overall, I actually, reading this article, they did a good job of briefly and succinctly and clearly talking about what it means to get that data from EMS. Hospital data. This is a small one out of Canada. 10 opioid overdoses reported last week, health unit says. Now, especially when we start looking at our news stories that are talking about, 82,000 overdoses, 10 is like, that's so small. Well, the health unit's not that big either. This is local reporting, and it's still very useful. This is a time when like granularity and regionality of hospital-sourced overdose data is not a bad thing, because the whole point of the story is in our community, there's a spike. Watch out, be aware of this. You obviously can't overgeneralize this and apply it anywhere else, but if what you're going for is that regional story, this is a great source of data. Versus this is looking over all of Alaska. They're looking at non-fatal opioid overdoses. They're going down. We're still not really sure why they're going down. This is another great use of EMS data. You're looking at a larger injury burden from fentanyl rather than just looking at fatalities. And this study is actually looking at ED visits, which are going to be more inclusive than just inpatient hospital. However, you're still going to miss anybody who declines to go with EMS. Medical examiner, this is a local one looking at Palm Beach County in Florida. 46% drop in opioid overdoses, medical examiner reports. County level, it's great. And one thing I really liked about this article that I didn't see in a lot of them, when this article talked about overdose deaths, it did it in the setting of the fact that total overdoses were increasing. Because if you think about it and you say, well, our overdose deaths have dropped 46%, and our total overdoses have dropped 46%, your fatality rate is staying the same. But if your total overdoses are increasing like they are in Palm Beach County, but your overdose deaths are dropping, then that really, really emphasizes that, more people are overdosing, but a much smaller percentage of them are dying. And their takeaway from this, from their health experts, were this is because we are making naloxone so easily accessible in the community. So comparing those sources of data is really important to actually getting to the answer of like, great, what does the data mean? And your readers aren't necessarily going to want to put all those pieces together for themselves. So being able to say we looked at the medical examiner reports, and in the setting of this EMS data, also, here's our conclusion. Otherwise, you can draw two wildly different conclusions if you're only looking at the medical examiner. NPDS, fentanyl exposures reported to kids. Like I said before, voluntary reporting. At this point, so many fentanyl overdoses come into emergency departments. Most of them are not reported to a poison center because your average emergency department physician does not need a toxicologist to tell them to give naloxone. But we still see more reporting on kids than on adults. Generally, though, living patients only. So we may not get information about fentanyl exposures in kids that immediately resulted in fatality without any other kind of healthcare involvement. Obviously, severity bias, if a kid just got sleepy at home and then they never went into a healthcare facility and they, never got sicker, that kid would never get tested for fentanyl. And we wouldn't know if there was just a very, very small contact exposure in the home. This article, which was through ABC, did a really good job of focusing on just 2 or 3 takeaways from what was a more complicated set of data, and still had a sentence that mentioned briefly the limitations of NPDS. And then we come back to CDC. If you're looking at the National Vital Statistics System, it is the provisional drug counts only, and they may change in time if you check back in 3 months as more things have been reported. It is a 12-month rolling period. So in this particular situation, it was December's report. So it was December 2023 through December, ending in December 2024. If you get delays in some states that have very, very impactful data, you could see a very big change. And that's maybe a little bit more likely because your states with a ton of data might be late getting it in because they are overworked. So millions of publications. What are we doing? Where are we at with this? So overdose stories in popular press. There are more than 1,000 new scientific publications that are PubMed indexed every year that have the word fentanyl in them. So like 3 PubMed indexed things every day come out that involve fentanyl. That's a ton. It's unsurprising. It's the leading cause of death in adults 18 to 44 years old in the United States. So there's going to be a very durable public interest in this. We're doing a lot of research. And if anything comes out of any of these stories that seems interesting, there's a high chance of it getting picked up and published. There has been and will continue to be a pressure on popular press to limit word count and increase how sensational something is. So your headline is just going to be a few words, and they're going to want to come out very strong. So you may end up with stories that, even if inside of the story you get a little bit more into the details of it, you can still end up with stories that are very sensational and may not completely reflect an accurate picture. Like, if you see money on the ground and you pick it up, it could kill anybody. Watch out. Is that actually what's going on? Yeah, probably not. So what happens when we end up with stories that are confusing or offer kind of conflicting data on if things are improving or getting worse, or if people are in danger? What does that lead to? So people have to be able to trust that when results are presented, they are based on sound methods and they're the truth, or as close to the truth as we know it, and that our recommendations based on that research are, based on a solid foundation and actually going to help people. These are complex issues, and if we can't verbalize them well, the understanding of not just like the general public, but the people who are in charge of writing our legislation, our regulations, who may not be, public health experts or epidemiologists or physicians. They're potentially, lawyers. They could be very good ones. They went to law school. I certainly didn't. I don't know how to write a law, but they may not understand the complexity behind these issues. And if we can't do a good job verbalizing them, we are not setting them up for success when they try to respond to these health emergencies. So we need to be able to lay the groundwork for the people who are making the response to make good responses. How can we do that? So nuance is very difficult, especially if you are in a situation where you've got a few minutes to talk to somebody and they are going to try to distill everything down into the most concise language possible. That is not an environment that nuance lives in easily. So going in, identify what your goal is. Very often in public health, it is education and awareness. And try to distill what you have to say, what you want people to take away, into just like a couple key points, including what you want them to take away about the limitations. Avoiding jargon and just letting people know, like, this data does not include, X, Y, Z, and offering some kind of example on how that impacts your data. So not just saying this doesn't include fatalities, saying this doesn't include fatalities, which means that people who die at home and never contact EMS and are found later are not included in this, or some version that lines up with your research. If something has been published recently that your study is in conflict with, or that your story is in conflict with, you don't necessarily need to be able to, explain the conflict, because you may not have an explanation, but also don't just necessarily ignore it. because people will see both of these stories and they may not know how to put them together. And I mean, this is sort of it feels silly to say, but if somebody asks you a question and you don't know the answer, just say it. Uh, be straightforward. Our data that we use, particularly and increasingly as we lean more and more on these very large data sets, very complicated, and it can be even small changes in your question that you're asking. You could find that your data set very rapidly becomes the wrong data set with which to answer a question. And if someone turns your research just a little bit and says, well, but what about this? You may not be able to answer it off the top of your head based on, the numbers you're looking at, and that is okay. So looking back at these from the beginning of the very beginning of the presentation, conflicting news stories. So this first one, fentanyl deaths, it's local ME reports specific to Yakima County. We know that in 2024, more people died than in 2025 for where we are right now. This is an accurate report, but just for Yakima County. The health alert is for opioid overdoses because this is coming from EMS groups. This is looking at the burden. A lot of these people did not go to a hospital. So not actually in conflict with any of the other stories, but is very important to note that difference because more people overdosing, but fewer of them dying. And as for the last two that were talking about the drug deaths going down and then going back up, that last one is based on the provisional data. And if you go look at the provisional data in the month since that was published, they have changed it. And instead of reading 82,000 for the predicted value in January 2025, they've decreased it to 79,900. So in fact, it is no longer reported as increasing. It is now reported as a continued decrease. 0.2 cases still pending investigation, but as you can see, that's pretty par for the course. So takeaways on this, data is complicated. Different sources have different drawbacks. Be aware of the limitations of these different sources when you are a reader. And if you are trying to communicate this, just be clear about what your message is and what your data is saying, and very importantly, about what your data cannot say. Thank you so much for listening.
All right, let me refresh Hoover here and see if we get any questions coming in. Thank you, Dr. Cowdery. There were many moments during this where I was chuckling to myself, just like, you mentioned PubMed, and when I was getting my degree in public health, I lived in PubMed and like had to ask myself and remind myself like a lot of these points here. And I'm chuckling at like there's so many layers to this. You have a
Mhm.
publication, a data set,
Mhm.
an article, what have you. And it could be the best science ever, the best data ever. And even the best data has limitations. But then you
Mhm.
have some news source or additional
Mhm.
publication that's writing up on it. And they may be super well intended and they may intentionally or not overlook something. And so just
Mhm.
that data can go through so many different
Yeah.
changes, even though the data stays the same.
Yeah, yeah, yeah. And I think that it can be very easy when you start whether you're just reporting health statistics or whether you're making a publication and you have your audience in mind and you present your data with this idea that your audience has the exact same framework as you. And then the second something gets taken up by popular press, your audience is now likely far broader than you had ever considered, and that framework is no longer shared. And it can be so easy for data to be completely changed in its interpretation, and that can be very challenging to get on top of when you want to make sure that your data is being presented in what you feel is the most accurate way possible.
Yeah, yeah. There's that, the classic idea that like, oh, data doesn't lie, math doesn't lie, stats don't lie. It's like maybe true, arguable, but like even with all the best intentions, it's so easy to
Mhm.
mislead with data. And I think,
Yeah,
the story you brought up a few times of making sure I've got my directions correct, um, increase in overdoses, but decrease in fatalities. Those are
yeah,
two very important points to hold next to each other and be so easy to take them out of context from one another. And
yeah.
that has a very different meaning and implication for, what may be really going on in that jurisdiction.
Yeah, yeah. And they are both, it's like you said, so important to have both of those numbers to put together, and you can't easily get either number, both numbers from the same place.
Yeah. Yeah. And it's something I try to be very aware of when uh leading a given like training. If I'm teaching
Mhm,
a PTA or PTSA about like vaping and
mhm.
cannabis, our nicotine data is going to look very different than what they expect it to look if they're assuming that the Washington Poison Center is tracking every single time someone is vaping, period.
Yeah,
And I've always tried to take a moment to give those caveats of like, no one's required to call us about anything. Like, so this is
yeah.
going to be underreported. And when folks see for context for you all, for our vaping and our nicotine data, almost all of those cases are for little kids under the age of 6. And when most folks are asking me questions about vaping, they're coming from a perspective of working in schools or being a parent to someone in schools where vaping is quite prevalent, but those cases aren't coming to us. But um, yeah, yeah. It's so important to give the right context and the right setting for
Mm,
any data we talk about.
for sure, for sure.
I'm also one of the points that again made me chuckle, and I want to read the full article now because the title worked, but this idea that sheriff
Oh,
warns that picking up folded money could kill anyone, like
yeah,
really feels like
yeah.
a description of a B-rated horror movie, kind of like
Yeah. And I mean,
yeah.
in that situation, that was there were more than one there was more than one story published around that same time, but it was all based around a social media post that was made by a law enforcement officer when um, a piece of folded up money was found, and somebody had symptoms after touching it, and they were driven to a hospital, and on the way there their spouse also has started having symptoms. And the article in question actually, they talked to a number of physicians, and they, discussed dermal absorption of fentanyl, um and how, we really have to try pretty hard if we're doing fentanyl patches to dermally absorb fentanyl, and that just touching is, generally considered to be relatively safe. Don't rub your eyes afterwards. But that certainly isn't going to stop them from making a very sensationalist headline.
Yes.
And then
Yeah,
if people just read the headline and don't click through to the article, they have taken away a piece of information, whether or not it is the piece of information we would have wanted them to take away.
yeah, absolutely. We actually do have a question now in the Q&A box over here. Um, what do you think the best data source is for finding out the route of exposure for overdoses, such as ingestion, inhalation, etc.?
That's a really great question. So, I, if you are wanting to get that data in association with fatality data, I don't think that the ME reports are going to be your way to go, because those typically do not necessarily have the route of ingestion. For all overdoses, NPDS is actually really nice in that it usually does give you a route of exposure. But uh, it I think it would depend on what you were specifically looking for. I probably would end up either knowing nothing else about what question I'm trying to answer. I probably would end up thinking that I'm gonna go with either local poison center data, like in a single center, or an NPDS search if I think I can still get the data I'm looking for. And if I really wanted to get in the weeds, then I would try to do a large hospital that's got a lot of patients to try to get some very granular data from like hospital chart requests. But my first go-to would probably be single center poison center, where I can get all of the details from individual charts that I want, including pretty reliably the route.
So all right, I'm going to do another refresher here, see if others come in. I'm not seeing other questions pop in, but folks, if you do think of any, by the time I'm done saying all of this, please hit us with those. And feel free to send us some questions after the fact. Feel free to reach out through Hoova, through our emails. We've posted those in a few different locations now. I was thinking of how to phrase this, Dr. Cowdery, that might, we were in a session together earlier today, and you're starting to get my moderator MO in my style. And one of my classic ending questions is like, if you could distill it down to one takeaway, what would it be? But that doesn't feel like the best question for this when that sort of slaps the point of the session in the face. So I'll
I,
simplify that.
I
Oh, go ahead. Go
I
ahead.
don't even think it necessarily does, because one of the points I think here is that you are going to be asked to distill down your message.
There we
And
go.
you are going to, especially if you are a public health researcher, if you are looking at any of these, if it is part of your job at all to ask these questions or communicate these answers, you're going to have your hands on something very complex, and someone is going to ask you to distill it down to one thing. And my piece of advice is, before you go into any of those conversations, think of 3 things that are the biggest takeaways for what you want your data to say and what you do not want your data to say. And just be very clear about them. And, I like one of my 3 things to be what I'm not saying with this data, because if in fact there is something that I really want to make sure is not misunderstood, because it can be very disappointing to run into that situation. And you want to give all the complexity. You want to really transmit this, but many times that's just not possible. So, like, go in knowing, like, if I can only put one thought in, what is it? And what do I really not want it to be?
I love that. I legitimately love not just the what is it, but what is it not? And I think that is so crucial and important.
Yeah.
I also love that between how I asked that and how you answered that, that was a meta kind of journey we went on. So thank you. Thank you for doing that. That was excellent. All right, folks, I'm going to do one final little refresh on Hoova, but I'm not seeing anything else pop up. We so appreciate you joining us today, Dr. Cowdery, twice. So you really deserve a bit of a break after this. Um, Now, folks, for those who are still on this session, we'll have a bit of a break following this, and then we'll reconvene at 2:30. I hope to see all of you there. And Dr. Cowdery, always a pleasure. Thank you so much. All right, take care, everybody.